Thank you so much for the introduction and for the invitation to be here today. Congratulations on the wonderful conference. It's certainly humbling to follow these wonderful speakers and experts in the field, but I'll do my best today to talk to you about precision medicine and the treatment of inflammatory bowel disease. Just one disclosure. So we'll talk a little bit about the what and why of precision medicine for treating inflammatory bowel disease, a little bit of what you've already heard, but we'll expand upon that. We'll talk about how the future is actually now, how we can incorporate precision medicine in today's clinic, and what's on the horizon for precision medicine in treating inflammatory bowel disease. What do we have to look forward to? What are the most promising findings so far? So as the other speakers have mentioned, precision medicine for inflammatory bowel disease, in short, means getting the right therapy, in most cases, the right drug at the right time, not too early, not too late, for the right patient, those who need it. And really, this has to go beyond the traditional clinical predictors that we have always used in terms of age, disease distribution, endoscopic severity. We know that these types of clinical predictors are insufficient, and that contributes to why our patients are not getting the outcomes that they want and that we want for them. And so really what this means is that defining aspects of precision medicine to better treat our IBD patients is a major unmet need. So what does this look like? Well, it really looks like moving from what's here on the left, a one-size-fits-all approach, where we think of a IBD population as homogeneous, and we just pick and choose from drug A, drug B, drug C, or drug D, and assign them to the patients, to really using a more personalized approach, perhaps utilizing multi-omics, incorporating aspects of the patient's phenotype, of the patient's proteinomics, of their genetics, of their transcriptomics. And in doing so, we identify that this population is actually quite heterogeneous. And we separate this population in order to better select therapy, both to achieve a safe response, but also the best response that we can get for that patient. So once we've divided these patients up into the groups that they truly belong to, give them the treatment that seems to best match that stratification, then we use precision medicine to facilitate our monitoring, both monitoring of disease activity and of the drugs that we are using. So, a lot of the speakers have talked about what we have in the future, and I think that there's much potential there, and we haven't really realized that yet, but we have had some progress. We've had progress in predicting and monitoring response and a precision technique using therapeutic drug monitoring and using non-invasive markers. We've also had progress in predicting adverse events, particularly immunogenicity to anti-TNF medications and thiopurine-induced myelosuppression. What about therapeutic drug monitoring of anti-TNFs? How do we predict response? How do we use a precision technique with this? Well, as you know, generally higher anti-TNF trough concentrations get better outcomes, and patients who aren't able to achieve adequate trough concentrations, adequate blood levels of the drug, are at higher risk of failure, both from a primary and secondary standpoint. And a really nice illustration of this is the PANTS study. This is a study that looked longitudinally at about 1,500 Crohn's patients treated with infliximab or adalimumab and looked at factors associated with response. And the only factor that they found that was associated with primary non-response was a low week 14 drug concentration. And they identified cutoffs for maintenance, week 14, week 54, they were the same, 7 for infliximab, 12 for adalimumab. So this is just one study illustrating the importance that we get our patients adequate drug concentrations when treating them with anti-TNFs. And we can add that to a lot of our other current knowledge about therapeutic drug monitoring for anti-TNF therapy. And this allows us to personalize our treatment decisions in these patients in terms of how do we monitor these patients, in terms of when do we check their drug levels? How do we decide to escalate a patient's therapy, whether that means increasing a dose, a frequency, or adding another medication? How about de-escalation? How does it guide us in lowering doses or perhaps going from combination therapy to monotherapy with just an anti-TNF? How does it inform us about how to treat a patient that is not doing well? It tells us whether we should use in-class switching or out-of-class switching, meaning in-class switching for a patient who perhaps has developed immunogenicity and might benefit from a different TNF medication, or out-of-class switching for so-called mechanistic failure, where despite very high drug concentrations, the patient is not getting the response that we want. In terms of thiopurines, we can also use therapeutic drug monitoring. As I know you are familiar, we can measure thiopurine metabolites, and in particular, 6-thioguanine is thought of as the therapeutic metabolite, but it can also, of course, cause myelotoxicity. And so we have a therapeutic window for this drug. For monotherapy, looking at about 235 to 450 in order to maximize response while minimizing the risk of myelosuppression. And there have been multiple studies looking at combination therapy as well. And although this data is not as solid as for monotherapy, it appears a cutoff of about 125, or at a very minimum somewhere in the 100 to 150 range, is a goal here to prevent immunogenicity and optimize our outcomes when using combination therapy. As you know, when you get thiopurine metabolites, you also get 6-MMP, 6-methylmercaptopurine, and we can, although we're getting ahead of ourselves here talking about adverse effects, but we can minimize adverse effects by trying to keep the MMP below 5,700 in order to minimize the risk of hepatotoxicity. And of course, when we're talking about precision medicine, we're talking about omics. So in proteomics, we have our non-invasive monitoring. We're very familiar with CRP and calprotectin and their strengths and weaknesses. Of course, CRP is not sensitive. We know that you can have significant luminal inflammation. Even if it's normal, it's not specific. We know it can be caused by inflammation that's outside the gut. And so it's helpful, but important to understand that the limitation of this aspect of proteomics, CRP is not an adequate treatment target in the treatment for inflammatory bowel disease. Calprotectin, though, is better. We know that normalization predicts endoscopic healing. So if we have our patient on a therapy and calprotectin is normal, that is a good prediction that they're going to do well with that therapy. And we also can use this for thinking about monitoring patients for their risk of relapse. We know that elevations that are not associated with symptoms and increased trajectory of calprotectin reliably can predict an upcoming clinical relapse in an asymptomatic patient, and that relapse can occur within the next few months. So that's a signal to evaluate more closely or perhaps escalate therapy. Still, this is there are some limitations with calprotectin that you are aware of. It depends on the study. What cutoff are we using? Certainly less than 50 is quite normal, predictive of endoscopic healing. But in that 50 to 250 range, there is ambiguity in the data. And also the assay can depend on what the cutoffs are. And so you have to be very careful in how you're interpreting. Nonetheless, this is a useful way of monitoring our patients and in a precision way using proteomics. Moving on to predicting adverse events, well, we have now a tool to predict immunogenicity to anti-TNF therapies. And this again is from the PANTS study. They looked in this case at about 1,200 patients with Crohn's disease treated with an anti-TNF therapy with or without an immunomodulator. And they measured their anti-drug antibodies prospectively, longitudinally, and then performed a GWAS to see if there are any gene associations with the development of immunogenicity. And there is a remarkable association that they found that with HLA-DQ-A105 being predictive of anti-TNF immunogenicity, both to infliximab on the left and adalimumab on the right. Impressively, for patients treated with infliximab monotherapy, meaning without an immunomodulator, they developed rates of immunogenicity. If they had one of these alleles, they developed rates of immunogenicity of over 90%. And conversely, patients treated with combination therapy with an immunomodulator without a copy of this allele, their immunogenicity rates were much, much lower, on the order of about 40%. So this is a very big difference and can help us in stratifying our patients' risk with regard to developing antibodies to anti-TNF therapies. We can also stratify a patient's risk for antibodies to anti-TNF therapies by just looking at their trough concentration. So this is an elegant abstract presented by Ryan and Garo and colleagues at this most recent GDW, where they looked at patients' infliximab trough concentrations relative to whether they had antibody to infliximab that was detectable. And then they stratified this by the patient's 6TG level. These patients were treated with immunomodulators. And you can see that for all the patients who had an infliximab concentration greater than 5, regardless of whether they had basically circulating 6TG or not, they had negligible levels of immunogenicity equivalent to those of vedolizumab or ustekinumab. However, as infliximab levels became lower, rates of immunogenicity went up. And you can see here that if you had an infliximab level in the 1 to 5 range, but a high 6TG, meaning over 150, you were still protected. However, in all lower ranges, you were at high risk of developing immunogenicity. And so we can use this to monitor and risk stratify our patients in terms of whether they should be on combination therapy or monotherapy, and what dose and metabolite goals do we have for those patients on combination therapy. We know that we can predict thiopurine-induced myelosuppression using genetic markers. We're all familiar with TPMT, thiopurine methyltransferase, and its role in metabolizing thiopurines. But the new kid on the block, if you will, is NUDT15. And this is another gene associated with variants of which are associated with thiopurine-induced myelosuppression. It's been validated originally in a South Korean population, however, subsequently has been validated in multiple East Asian populations where the variants are most prevalent, but also in European population and Indian populations. And so most likely this is a pretty broadly applicable gene and something that we could consider incorporating into our practice. However, of course, validation in more specific epidemiologic cohorts would still be helpful. And so if we're trying to predict adverse events, how can we incorporate these pieces of precision medicine into our practice today? How do we use the future of precision today? Well, we can use it to predict immunogenicity to anti-TNFs even before we start therapy by checking for HLA-DQ-A105 and then deciding whether we're going to use combination therapy or monotherapy or perhaps a different agent for that patient. And during infliximab therapy, trough levels greater than 5 prevent nearly all antibodies to infliximab. And so we can use therapeutic drug monitoring to predict and stratify our patients as well in terms of dose changes or addition or subtraction of combination therapy. And for thiopurine-induced myelosuppression, we can use pre-therapy evaluation with TPMT and NUDT15. What about the future? Well, the future is here, but there's much more to come. And I think that there is a lot of promise here. Nothing that is ready for prime time, but we can look at things like molecular endoscopy. We can look at things like transcriptomics, genetic markers, immunoprofiling, and looking at the composition of the gut microbiome in order to try to stratify patients to therapies and predict their response to therapies. Some of these more promising ones I want to highlight here, for example, molecular endoscopy. So here you see two pictures of inflamed bowel. And what they've done here is stained mucosal TNF. So the TNF positive cells on the mucosa. And they've done this with endoscopic confocal laser endomicroscopy in order to see, well, do the patients with more mucosal TNF versus less, do the patients with more respond better to therapy? And in fact, that they found that they do respond better to TNF therapy. And in a different study, they looked at the same concept for vedolizumab, looking at mucosal alpha-4 beta-7. And in fact, in that study as well, they found that higher levels of alpha-4 beta-7 mucosal expression were correlated with better response to vedolizumab. And so this is something that perhaps in the future we'll be incorporating into our endoscopic practice. Transcriptomics are also a promising area, particularly for predicting anti-TNF response. Not ready for prime time, but two proteins that are certainly worth mentioning. One is oncostatin M, which is part of the IL-6 cytokine family. And higher levels of this are associated with higher disease activity and also predictive of non-response to anti-TNF therapy. This certainly needs a lot more validation, but holds some promise. And perhaps more promising is TREM1. And this can be measured either in tissue or in serum. And lower levels of this drug predict response to anti-TNF. So higher levels, less response, lower levels, more response. And interestingly, this is not true of vedolizumab or ustekinumab. So what that tells us is that this is truly a potential marker for TNF response rather than drug responses in general. We can also look at immunoprofiling, meaning looking at, for example, cytokine concentrations and how that can help us. So here we have some data that we can predict anti-IL-23 response using the serum concentration of IL-22. IL-22 is an upstream regulator of IL-23, and in a phase 2 trial of brazikumab, which is an anti-IL-23 antibody, a lower baseline concentration of IL-22 predicted response. So potentially we could measure IL-22 in the future as a way to determine whether an anti-IL-23 drug is a good option for our patients. So certainly there are a number of challenges to incorporate these types of techniques into our daily practice. And though we have our existing biomarkers that we talked about, how we can incorporate precision medicine today using non-invasive monitoring for inflammation like CRP or calprotectin, how we can predict myelosuppression with thiopurines using TPMT or NUDT15, how we can use therapeutic drug monitoring and measuring of anti-drug antibodies for anti-TNF agents, and even looking at metabolites for thiourines. We have this today, but what we need to move towards is looking at our potential biomarkers, our exposome, our genome, our transcriptome, our microbiome, our immunome, and using that, we stratify our patients into what therapy that they will best respond to. We predict their response as well, and we personalize their monitoring, leading to more individualized care, individualized therapy, and potentially in the future, prevention and cure. So, there are obviously many steps to go from left to right here, but there is progress slowly being made, giving us hope and our patients hope. And I think there is much promise in this area and an exciting future. Thank you very much for this opportunity to speak to you today. And I'm happy to take questions if we have time for them.
Thank you a lot, Dr. David.